Ladies and gentlemen, please rise to welcome the ceremonial procession. To invite Professor Chandanie Wanigatunge, our orator, Dr. Upul Disanayake, President, Ceylon College of Physicians, and the Joint Secretaries of the Ceylon College of Physicians, Dr. Chiranti Liyanage and Dr. Chanaka Veratna, to join the head table. You may be seated. I now cordially invite Dr. Upul Disanayake, President, Ceylon College of Physicians, to introduce our orator.
Ladies and gentlemen, it's my pleasure to invite the orator today for the EV Peiris Oration 2024, Professor Chandanie Wanigatunge. Professor Chandanie Amila Wanigatunge is an eminent figure in the fields of pharmacology and internal medicine. She currently holds a position of Senior Professor and Chair of Pharmacology at University of Sri Jayewardenepura and serves as the Deputy Director of the Postgraduate Institute of Medicine, University of Colombo. Professor Wanigatunge completed her Bachelor of Medicine, Bachelor of Surgery with honors from North Colombo Medical College in 1992, obtaining distinctions in microbiology, parasitology, and medicine. She earned her MD in medicine from the Postgraduate Institute of Medicine, University of Colombo in 2000 and became a board-certified specialist physician in 2002. Her academic career at University of Sri Lanka spans nearly 3 decades, beginning as a lecturer in pharmacology in 1995. She was appointed professor in pharmacology in 2014 and elevated to the position of chair professor in 2016. Throughout her tenure, she has made significant contributions to postgraduate education and pharmacological research. Professor Wanigatunge has received numerous awards for academic and research excellence. Notably, she was awarded the Henry Rajaratnam Award for Best Paper in Endocrinology by the Ceylon College of Physicians in 2016 and President's Award for Scientific Publications in 2014 and 2015. Her extensive research on rational drug use, particularly in older adults, and the rational use of antibiotics has resulted in over 38 peer-reviewed journal articles and 90 published abstracts. In addition to academic achievements, Professor Wanigatunge has been deeply involved in shaping national policies on healthcare and drug regulation. She has served as the chairperson of the Forum for Ethics Review Committees in Sri Lanka since 2015 and has played a pivotal role in the development of national guidelines for the use of antimicrobial agents. Her leadership in ethics and clinical trials has been recognized both nationally and internationally. Professor Wanigatunge is a fellow of the Royal College of Physicians of Edinburgh and London and the Ceylon College of Physicians. In 2019, she was elected president of the Ceylon College of Physicians, demonstrating her standing as a leader in the medical community in Sri Lanka. Her research, teaching, and leadership continues to have a profound impact on the medical and academic fields, both locally and globally. Ladies and gentlemen, the E.V. Peiris orator for today, Professor Chandanie Amila Wanigatunge.
Thank you, Upul, for your kind words of introduction. The President, the Council, and the past Presidents of the Ceylon College of Physicians, the family members of late Dr. E.V. Peiris, members and fellows of the Ceylon College of Physicians, and the Royal Colleges of Physicians of London and Edinburgh, ladies and gentlemen. I stand before you honored and humbled. I thank the President and the Council of the Ceylon College of Physicians for this singular honor and hope that at the end of this, I have justified their selection. Let me begin by paying tribute to one of Sri Lanka's greatest physicians, the late Dr. Ernest Victor Peiris. Born in Badulla in the hills of Ceylon, Dr. E.V. Peiris hails from a family of eminent physicians. Both his father and father-in-law were physicians, and his wife, the late Dr. Philin Peiris, was a specialist pediatrician with an interest in pediatric chest diseases. Dr. Peiris received his primary and secondary education at Royal College, Colombo, and entered the University of Ceylon to study medicine. He graduated with first-class honors and distinctions in medicine and obstetrics and gynecology. Following junior resident appointments, he proceeded to the United Kingdom and obtained membership from the Royal Colleges of Physicians of Edinburgh and London. On his return to Ceylon, he obtained his MD and was appointed consultant physician to Colombo North General Hospital. In 1960, Dr. Peiris was appointed consultant physician to General Hospital Colombo, a post he held with distinction up to his retirement. A versatile sportsman, he represented Royal College in cricket and rugby and captained the university rugby team. A profound knowledge of basic principles of medicine, a lively interest in the most recent advances, and the highest standards of integrity he set for himself made Dr. Peiris a clinician of the finest caliber, a teacher par excellence, and one of the most admired and beloved physicians of his time. In recognition of his services, the Ceylon College of Physicians awarded the fellowship of the college to one of our pioneering members. He was also elected fellow of the Royal Colleges of Physicians in both London and Edinburgh. Ladies and gentlemen, Bansky once said, and I quote, "You die twice, once when you breathe your last, and a little later when somebody says your name for the last time. In this respect, we can safely assume, as long as the Ceylon College of Physicians exists, Dr. E.V. Peiris will remain immortal. That's a declaration. I have no interests financially or otherwise with the material that I'll be presenting today. Ladies and gentlemen, infectious diseases are caused by microorganisms such as bacteria, viruses, fungi, and parasites, and they are a global problem. In 2020, in the public sector of Sri Lanka, infections were the second leading cause of all hospital admissions and the third leading cause of all hospital deaths. Bacteria are relatively complex single-cell structures. They can reproduce on their own and can survive in different environments, including extreme heat and cold, and even radioactive waste. They can invade and survive in the human body. Most bacteria are harmless. In fact, some of them help us. Fewer than 1% of bacteria can cause diseases in people. When they do, they can attack any part of the body, and sometimes the diseases they cause can be fatal. In 2019, global deaths due to common bacterial infections accounted for 7.7 million, second only to ischemic heart disease as the leading cause of death. This highlights why reducing bacterial infections is a global public health priority. To treat bacterial infections, we need antibiotics. The discovery of antibiotics, ladies and gentlemen, stands to date as one of the most critical advances in medical history. In 1928, Alexander Fleming found a petri dish on his workbench filled with a strain of mold. It was not only thriving, but also limiting the growth of bacteria. He named this penicillin and showed that many of the common human pathogens were strongly inhibited by it, while many others were unaffected. Ernst Chain and Howard Florey went on to discover penicillin's therapeutic actions and how to isolate and concentrate the germ-killing agents in penicillin. For their work, Fleming, Chain, and Florey were awarded the Nobel Prize for Physiology or Medicine in 1945. Before penicillin, even a scratch could kill a person. Thanks to penicillin and many other antibiotics that were discovered subsequently, we are here today and many lives have been saved. Today, antibiotics are used to treat the most common bacterial infections in outpatient or primary care. And in the hospitals, they enable us to perform medical interventions that would have been very dangerous or even inconceivable 100 years ago. Antibiotics work in many ways to kill disease-causing bacteria. But bacteria are resilient. They evolve and develop mechanisms to avoid being killed by these antibiotics. This is antibiotic resistance and is an inevitable consequence of antibiotic use. In short, use antibiotics, but you lose them. Bacteria develop resistance to an antibiotic within few years after it hits the market. More and more bacteria have now become resistant to most of the antibiotics that are available, resulting in superbugs. Infections caused by superbugs are difficult to treat, expensive, and are deadlier. Considering the magnitude of the problem, a global AMR emergency was declared by the World Health Organization in 2015. Resistant bacteria spreads from man to animals, man to plants, plants to man, and animals to plants. The consequences of these resistant bacteria are expensive and devastating. Prescribers, patients, or the public, and the quality of antibiotics could contribute to or prevent the development of antibiotic resistance. Ladies and gentlemen, over the next 25 minutes, I will present to you our work on some aspects of antibiotic use in Sri Lanka. In 1945, Fleming saw the future and sounded a warning about the misuse of antibiotics by the ignorant man and its consequences. And by the turn of the century, the World Health Organization identified 4 patient-related factors that contribute to antibiotic resistance: patients' misperceptions, self-medication, poor adherence to prescribed regimes, and advertising and promotion. As Sri Lanka does not allow direct-to-consumer advertising, that is, advertising either to patients or to the prescribers, we wanted to explore the other 3 aspects. When we searched the literature in 2012, there was nothing published about antibiotic knowledge from Sri Lankan patients. Interestingly, even in the South Asian region, there was very little literature to find. Therefore, we conducted a cross-sectional survey in an urban area to explore what people knew about and how they used antibiotics. Of the 400 randomly selected adults that we interviewed, 70.8% knew that antibiotics were medicines used for infections. However, their perceptions varied. Most of them thought they were germ killers or drugs that are used to treat infections in the broad sense of the words. Only 4.5% correctly knew that antibiotics are drugs to treat bacterial infections. Interestingly, 14.5% thought antibiotics were painkillers, and a small percentage thought they were drugs given for gastritis. 69% knew that the full course of antibiotics should be completed as prescribed. However, only 58.8% completed the course. 40% had taken antibiotics only until they felt better, and 11.5% retained antibiotics for future use. 19.8% believed that they could select an antibiotic for common infections such as coughs and colds and wounds. 37.8% had taken antibiotics during the 3 months preceding the study. Of them, nearly 50% had obtained antibiotics without a valid prescription. That is, a prescription given by a doctor for that particular instance. 76% had walked into the pharmacy and obtained antibiotics without any prescription. Some had got antibiotics by using prescriptions given earlier for a similar illness, while others had got them by showing the leftover antibiotics to the pharmacist. Some others had used prescriptions given to other people who had similar infections. 61.7% of our sample had taken antibiotics without a valid prescription at some point in their lives. 28% had received no information about the antibiotics. Their main source of information at that time was television and newspapers, and sadly, only 12% had got information from healthcare workers. We presented our work at the SLMA sessions in 2012. Ladies and gentlemen, when we have an infectious disease, it is nice to know what organisms caused it. It is especially good if we know for bacterial infections what bacteria caused the disease, and more importantly, what antibiotics would work against these bacteria. And that is called empirical treatment. So we start treatment before we collect microbiological samples. Now, empirical treatment is recommended in the national guidelines. And clinicians expect these guidelines to recommend the antibiotics that are most likely to work for a given infection. The downside, if they don't work, is that we will not be able to treat it appropriately and the recovery would take longer. We therefore conducted 2 studies. I'll present both together for ease, and looking at what was prescribed empirically for infections in patients with and without cancers. We selected cancer patients because patients who have cancers get more severe infections with more resistant bugs, and they are difficult to treat. We wanted to look at prescriber adherence to national guidelines and the appropriateness of recommended and or prescribed antibiotics to treat the selected infections. We collected pathogenic bacterial isolates of patients who had severe urinary, lower respiratory tract infections, and skin and soft tissue infections, and those who were given parenteral antibiotics, that is antibiotics through an injection, because they had severe illness. The isolates were recultured, and we assessed their sensitivity to both the prescribed and the recommended antibiotics. Data on the empirical treatment was extracted from the patient's notes. We analyzed the empirical antibiotics prescribed to see whether they were what was recommended in the national guidelines of 2016. Empirical therapy was considered appropriate if the isolate was sensitive in vitro to at least one of the antibiotics prescribed empirically. We analyzed 165 isolates from each patient population, 55 isolates each from each infection. The two groups are comparable, but the only difference we saw was that the mean hospital stay before cultures was significantly longer for patients with cancers. And this suggested that these are probably hospital-acquired infections. In both populations, and in all three infections, majority of the isolates were gram-negative organisms, with escape group and E. coli accounting to more than 90% of the isolates. These two groups are those that are most likely to develop resistance as time goes on. There was no significant difference between the proportions of commonly isolated bacteria between the two populations for respiratory and skin and soft tissue infections. However, E. coli was commoner in non-cancer patients with urinary infections, while Enterococcus species was significantly higher among cancer patients with urinary infections. The overall prevalence of multi-drug resistant organisms was higher in isolates obtained from cancer patients. Notable was the increased presence of carbapenem-resistant Enterobacteriaceae. In an attempt to combat antimicrobial resistance, the World Health Organization classifies antibiotics into three groups based on their spectrum of activity and therefore the potential to develop resistance. The WHO recommends using more antibiotics from this access group when treating infections. However, severe infections need broad spectrum empirical antibiotics to cover the most likely causative organisms. Therefore, the parenteral antibiotics recommended by the national guidelines for such infections are also mostly broad spectrum and therefore from the watch group. In our sample too, most of the empirical antibiotics prescribed for the three infections in both patient groups were broad spectrum antibiotics and from the watch group. No surprises there. 86.4% of those without cancers and 67.5% with cancers had been prescribed antibiotics as recommended in the national guidelines. However, empirical therapy was appropriate. That meant the organism would be killed. Only in 52.4% of the instances in patients without cancers and in 36.3% of those with cancers, suggesting that whether you gave guideline concordant therapy or you gave therapy based on experience is equally effective or not effective. We presented our work at scientific meetings and published in international journals. Ladies and gentlemen, in Sri Lanka, the outpatient care is shared between the public and private sectors, while inpatient care is mostly delivered through the public sector. It is still the same, but we see an increase in the services delivered by the private sector now. The country obtains medicines mainly through imports, with a small contribution from local manufacturers. National antibiotic consumption data is a proxy estimate of antibiotic use in a country and is a prerequisite when planning strategies to combat antibacterial resistance. As Sri Lanka had ABC data for clinical use only from the public sector, we surveyed the antibiotic consumption from countries' public and private healthcare sectors. A descriptive cross-sectional study was done to analyze the antibacterial consumption for 2017. We aimed to quantify and describe the national antibiotic consumption in Sri Lanka and to examine any differences in antibiotic consumption between public and private sectors. The survey method was adapted from the WHO methodology for a global program on surveillance of antimicrobial consumption. Selected key quality indicators of antibacterial consumption were compared between the public and private sectors. We extracted data from all available data sources. Our results showed that despite the public sector carrying a greater burden of inpatient care, the private sector consumption was 2.5 times more than that of the public sector. The top 4 groups of antibacterials consumed in Sri Lanka, according to the ATC classification, were beta-lactam penicillins, other beta-lactams, macrolides, and quinolones. Apart from beta-lactam antibacterial penicillins, the consumption of other 3 groups was more in the private sector, with a disproportionately higher consumption of macrolides and quinolones. All quality indices we calculated showed a disproportionately higher use of broad-spectrum antibiotics in the private sector when compared to the public. Notable was the consumption of ceftriaxone, cefuroxime, and meropenem, where the private sector use greatly exceeded that of the public sector. The consumption of broad-spectrum watch group antibiotics in the private sector was more than the consumption of narrow-spectrum access group in the public sector. Our findings were published in PLOS One. Ladies and gentlemen, medicines come as innovators and generics. And although less expensive, the generics are expected to be similar in efficacy to the innovator. However, low efficacy, low quality generic antibiotics are available and result in therapeutic failures and facilitate the development of antibacterial resistance. There is also a perception among the prescribers that generic products, especially what is available in the public sector, are of a lower efficacy. This is especially so for injectable antibiotics, where the WHO also does not recommend bioequivalence testing for parenteral generic antibiotics before they are registered. This perception may lead to prescribers asking patients to buy an expensive brand of the same antibiotic or to prescribe an antibiotic with a broader spectrum of activity, especially as these are used to treat severe infections. We therefore compared the in vitro efficacy of different brands of 5 antibiotics. 4 of those were among the most prescribed antibiotics in our previous studies. We selected vancomycin because it's an antibiotic effective against the MRSA, which was one of the superbugs we saw. All 5 are from the WHO's watch group antibiotics and therefore have a broad spectrum of activity. We selected the brand available at the MSD, hence in the public hospitals, and 2 other brands each from the antibiotics, which had the highest sales data. The antibiotics were tested against sensitive clinical isolates obtained from patients and standard bacterial strains. We check the minimum inhibitory concentration. That's the lowest concentration of antibiotics that greatly inhibits the growth of bacteria. And the minimum bactericidal concentration, or the MBC, which is the lowest concentration of antibiotics that kills the bacteria. Both are indirect markers of efficacy. What did we find? Contrary to the prescriber perceptions, we saw no significant difference in the MIC or the MBC between the different brands of the same antibiotic that we tested. Incidentally, similar results have been seen in other studies done globally, which have evaluated different brands of the same antibiotics that we tested as well. We presented some of our work at scientific meetings. Ladies and gentlemen, this is by no means the whole picture of antibiotic use in Sri Lanka. What I have attempted to do is to place our findings in the picture. However, a lot more of the picture remains unseen. Our work shows that the public misuses antibiotics, but more alarmingly, think that they know what they are doing, and worse, that they are right. It shows that laws and regulations have not been effective where it matters. Today, any one of us can still walk into the pharmacy and buy an antibiotic without a prescription. It shows that prescriber practices should also be reviewed, especially when giving things like giving antibiotics even when we know that the infection is viral. But we also thought that we need to be more careful when we use terms, generic terms like infections, bugs, germs, without being specific, probably leads to these misconceptions among the non-medical people. Although there was nothing when we started that study, these findings have been replicated repeatedly, even very recently across the country, which shows that we have really not been effective in addressing the problem. Our work shows that being concordant with the guidelines may not necessarily result in appropriate empirical treatment. It also showed that antibiotic prescribing based on experience is no better. To capitalize on good guideline concordance by prescribers, the guidelines should be updated regularly, in keeping with the rapidly changing antimicrobial resistance patterns. The work for the 2016 guidelines started in 2012. The college was represented by Dr. Ananda Vijayavikrama, Dr. Ranjan Premarath, and myself. It took us 4 long years to get that set of guidelines out by 2016. The updated one was released in 2024, 8 years after the first. That timeline is more than enough for bacteria to overtake us. Our work shows that as a country, we use more broad-spectrum antibiotics than we should, and we are at a greater risk of antibacterial resistance and the development of multi-drug resistant strains. The significant use of the watch group antibiotics in the private sector needs further exploration, especially as the prescribers, and more importantly, the bugs, are same in both sectors. Why then is this disparity? The work also highlights the need for accurate and complete record keeping for proper antibiotic consumption surveillance. We couldn't get all the data because of the problems with data keeping data. Our work shows that there is a good and a relatively inexpensive method to simultaneously evaluate multiple antimicrobial agents for potency, especially as a screening tool. The MBC can be used to evaluate formulations, specifically when we suspect there is contamination, because the MBC, therefore, will not be as good as the test. Our work leaves an important question unanswered. If the potency of the brands is the same, the work actually came because of a chance comment made by one of my colleagues who said, Why aren't you looking to see what we get in the hospitals are not effective? But we couldn't find anything to substantiate that claim. But then why do clinicians feel that what they have in the public hospitals is ineffective? Are there issues in transport and storage that can all affect the efficacy? Are there patient-related factors that can affect the outcomes? These are areas for further research. We had specific questions for which we went searching for answers. And what we found is what I shared with you today. They show both the good, the bad, and the areas that we need to work on and further explore. We have shared our findings with the relevant authorities and can only hope that they will not remain as mere observations. Ladies and gentlemen, the development of new antibiotics is expensive and time-consuming. The complete discovery of a typical broad-spectrum antibiotic from the discovery to market may take an average of 13 to 14 years and will cost anything between 150 to 600 million euros. This is excluding the extended costs for failed molecules and lost opportunities associated with increased cycle time. It is therefore not surprising that we have not had any new class of antibiotics being developed for the last 40 years. What is frightening is that if AMR continues like now, in less than 3 decades, global deaths from infections due to resistant bacteria will reach a staggering 10 million a year. Low-income countries and lower middle-income countries like us bear the significant burden of infectious diseases. South Asia is forecasted to be one of the super regions of bacterial antimicrobial resistant deaths. And these deaths will be more in those 70 years and older. Most of us here today might be one of those statistics. Rational consumption of antibiotics and combating antimicrobial resistance should not be owned by one group of people or one entity. That the Ministry of Health should provide leadership and act as the national focal point to combat AMR is not negotiable. However, interpreting ABC data and AMR data needs experts in relevant fields, and obtaining that necessary expertise is up to the Ministry of Health. Activities related to ABR are not the sole property nor the responsibility of selected groups of clinical specialties. All of us prescribe antibiotics, and therefore all of us need to be involved in working towards this goal. It is imperative that we join hands to help in the antimicrobial stewardship program launched by the Sri Lanka College of Microbiologists. These stakeholders must get the pharmacists and the patients involved, and it is only by working together that we can prevent living in the pre-penicillin era where every scratch could potentially kill. Ladies and gentlemen, what I presented today is a collective work of many, some of whom who are here today in this audience. I'm deeply indebted to my co-investigators who worked with me, shared their expertise, and we had an enjoyable journey. So thank you, Vatsala, Neluka, Tushari, Shalini, Dr. Benaragama, Savini, Ravindra, Danushka, and Chaturanga. Chaturanga's PhD was one of the highlights in this journey for me. I'd like to acknowledge our funding sources, the University of Sri Jayewardenepura, a research grant from which we did some of this work, and the Sri Lanka Association for Clinical Pharmacology and Therapeutics, who funded the data entry operator for the antibiotic consumption study. On a personal note, I'd like to acknowledge my parents for making it possible for me to be here today. I'm overjoyed that my father is in the audience. The two men in my life do not need special thanks. They know what they mean to me. However, I can only hope that I will not be asked this question again. I presume that I have answered it sufficiently. To all of you here today, thank you very much for coming. Your presence means everything. And in case I have kept you away from performing your civic responsibility, there is still time. Ladies and gentlemen, the last 30 minutes, I have stood on the shoulder of a medical giant. It's an exhilarating experience, a memory that I will treasure. But I'd also like to take a moment to acknowledge the one person who made it possible, the late Dr. Peiris, who sadly is not with us today, but I had the privilege and the pleasure of meeting her in 2019. Thank you very much for being here today.
Thank you, Madam, for that erudite oration. Ladies and gentlemen, please rise as the ceremonial procession exits the hall.